Hey guys, it is Ryan. I'm not sure if you know this about me, but I'm a bit of a fun fanatic when I can. I like to work, but I like fun too. It's a thing. And now the truth is out there. I can tell you about my favorite place to have fun. Chumba Casino. They have hundreds of social casino style games to choose from with new games released each week. You can play for free anytime, anywhere. And each day brings a new chance to collect daily bonuses. So join me in the fun. Sign up now at ChumbaCasino.com.
No purchase necessary. VGW. Void where prohibited by law. See terms and conditions. 18+.
Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Go check out reallifepharmacology.com. Get your free study guide on the top 200 drugs. Simply an email will get you access to that free resource. And obviously, we'll get you updates when we've got new podcasts available, as well as other new content. So go check that out at reallifepharmacology.com. All right, the drug of the day today is Ropinirole, or brand name Requip. This drug is classified as a dopamine agonist. With that said, what dopamine receptors from a mechanism of action standpoint does Ropinirole bind? It primarily binds D3 receptors, but it also does have some binding to D2 receptors. So if you remember mechanistically, and from a drug class perspective, antipsychotics block dopamine 2 receptors. And a drug like Ropinirole actually activates or agonizes. It stimulates the D2 receptor. So these two drugs can really kind of cause opposing type effects. So that's definitely an important thing to remember. And if you can remember some of the adverse effects of antipsychotics, you can expect, or what the antipsychotics treat, you can expect Ropinirole to have some of the opposite type activity. And we'll get into that when I talk about adverse effects especially. All right, let's talk about indications. So first and foremost, this drug was, I believe, initially created to manage Parkinson's symptoms. Having that dopamine action, remember Parkinson's, it's a lack of dopamine action in the brain, so it makes sense that Ropinirole could potentially be helpful for Parkinson's. Now, with that, carbidopa-levodopa is really the gold standard for treatment of Parkinson's, so in my practice, I really don't see it used very often for Parkinson's disease. The other primary indication for Ropinirole is Restless Legs Syndrome, or RLS, as it's frequently abbreviated. One thing with dosing between these two indications that you can usually pick it up 99% of the time, if you see Ropinirole immediate release, there is an extended release product too, but immediate release is used far more commonly. If you see that immediate release dosed once daily, and particularly at night, 99% of the time, that indication is going to be for Restless Legs Syndrome. Okay, so that's definitely an important thing to remember. In my practice, like I said, I see it used way more commonly for RLS than for Parkinson's disease. Now, with that said, it I would say 5 or 10 years ago, it was automatically the go-to first choice for anyone with RLS symptoms when we've ruled out other things, and I'll talk about that a little bit too in monitoring. But they have, I wouldn't say fallen out of favor, but the gabapentinoids are definitely being used a little bit more often as a potential first-line option as well. So that's like your gabapentin and pregabalin. So for RLS symptoms, drugs like dopamine agonists, like Ropinirole, and the gabapentinoids are the drugs most commonly used for those type of symptoms. All right, let's get into adverse effects. So if you remember what antipsychotics do, that can help you remember the opposite of what Ropinirole might cause here. So understanding that we've got dopamine agonist activity, From an adverse effect profile, you should recognize that nausea and vomiting are real common. And this kind of aligns with carbidopa-levodopa as well. Again, this is a dose-dependent adverse effect. So if you've got somebody on a baby dose of ropinirole at 0.25 milligrams once a day, that incidence of nausea and vomiting is going to be much lower than a patient that's maybe on 1, 2, 3 milligrams a day, for example. So again, remember the dose-dependent nature of these adverse effects. Also, to help you remember that, if you remember some antipsychotics like olanzapine, other dopamine-blocking agents like metoclopramide, those can be used to help treat nausea. So you can imagine ropinirole, with its opposite effects of antipsychotics, is going to induce nausea and vomiting as its adverse effect profile. Another important adverse effect to look out for is hypotension. If you go look at the package insert, I believe it says either hypotension or hypertension can happen. In my experience, hypotension is much more concerning and something we need to pay attention to, particularly if you've got elderly patients with dizziness and fall risk and all that sort of stuff. So pay attention to that blood pressure for sure. It's another reason why we don't get crazy aggressive with the starting dose. Well, we could run into nausea and vomiting a little bit more quickly without proper titration, but we could also send that blood pressure down a little bit quicker too and put them at risk for falls and things like that. Other adverse effects, fatigue, sedation, that can definitely happen with these agents. And then, of course, again, relating it back to antipsychotics and kind of opposite effects, we can cause hallucinations and impulse control behavioral issues, like gambling and excessive eating and things like that. Again, not crazy common, and as the dose escalates, it's probably a little bit more likely. But if you see some unique behavioral things happening with a patient that maybe you've just started this on or increased the dose, it definitely should be considered as a potential cause. And I also wanted to mention that it is recommended to taper off this medication. So in practice, I've seen a lot of patients on a drug like ropinirole for restless leg syndromes, and maybe they haven't had any symptoms for years. It's like, well, that's a patient where we can try to reduce polypharmacy, get that patient off that medication, but we're going to want to taper that down. And it's recommended to do that over at least 7 days. My opinion, being more conservative, as long as they're not having adverse effects or anything like that, I would probably do it over a few weeks or maybe a few months in some situations if they've been on it for a really long time, and or maybe they're at a really high dose as well. So again, important to avoid that risk for withdrawal type symptoms with this medication. So, and some of those withdrawal type symptoms, if you do have a patient that just maybe they've been on it a long time and they just stop at cold turkey, anxiety, insomnia, depression, maybe a burst in pain, that type of thing. So those are some common withdrawal symptoms that you could possibly see. All right, monitoring parameters. Obviously, you're going to follow restless leg symptoms and make sure that they're improving. If they're not improving, let's get rid of the drug. Other things to think about: blood pressure. I mentioned that hypotension risk. That is certainly going to be something you're going to want to monitor. And one other thing, maybe even before you start a dopamine agonist, you've got to assess iron stores and check labs like ferritin. Okay, iron deficiency can increase the risk for restless leg type symptoms. Okay, so we have to check iron first. We don't want to use an potentially unnecessary drug in a patient that may be short of a supplement like iron. Okay, really, really important to assess that in patients with restless leg syndrome. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for pharmacist board certification study materials like BCPS, ambulatory care, BCMTMS, geriatrics, Naplex, go check out meded101.com/store, S-T-O-R-E. Your support there, your purchases there will not only help you pass your exam, but also help support this podcast and obviously future generations of pharmacy students, nursing students, med students who want to pick up some practice pearls on pharmacology. Speaking of pharmacology, I've got a brand new book out, Meded 101 Guide to Nursing Pharmacology. I've got some really nice ratings from people already who have really enjoyed the book, found it really, really helpful. This is going to be a great resource for anyone going through pharmacology courses. I've designed it as basically a quick bullet point type reference categorized by disease state. And I've also threw in some bonus questions at the end where you can kind of test yourself and make sure that you're retaining some of the knowledge. So if you're looking for a big, long, wordy textbook, this is not your book, the Meded 101 Guide to Nursing Pharmacology. If you're looking for quick hitters, some of the most important things that are tested on, as well as some of the most important things you're going to see in clinical practice, this is a great reference guide for you. And you can find that at meded101.com/store under our Amazon Books tab, or you can search for it on Amazon as well, of course. All right, let's wrap up with drug interactions. So first and foremost, I alluded to it with mechanism of action. Dopamine agonists and antipsychotics can kind of create this yin-yang type of effect where they're opposing each other's action. Okay, antipsychotics block dopamine. Dopamine agonists were stimulating some of those dopamine receptors, so they can definitely counteract and oppose each other's effects. So pay attention to that and make sure we're using medications properly. Hypotension. Think about that, additive effects, drugs like PDE5 inhibitors, so your sildenafils, obviously any drug that can lower blood pressure that we're using for hypertension management, adding on a dopamine agonist could have additive type effects there. And then the last one I wanted to mention was CYP1A2. So ropinirole is broken down to a significant extent by CYP1A2. There are a list of quite a few drugs that inhibit CYP1A2, but I would say that list isn't really commonly used drugs, so it definitely might be something you want to look up. However, one of the most common drugs that inhibits CYP1A2 is ciprofloxacin. So in the situation of, maybe you've got somebody with pyelonephritis or something like that we're treating, we're using ciprofloxacin for, that adding on that drug could increase the concentrations of ropinirole and obviously increase the risk of that adverse effect profile. Hypotension, hallucinations, nausea and vomiting. So that definitely is something to be aware of because, quinolones like ciprofloxacin are used on a somewhat regular basis for various types of infection. All right, well, that's going to wrap up the podcast for today. If you enjoyed this episode, share us with colleagues, classmates, students, preceptors. Share the Real Life Pharmacology podcast by email, social media, however you want to do it. I greatly appreciate that, helping to share and spread education. Leave a rating review on iTunes or Spotify or whatever platform you are listening on. That helps us get exposure as well and allows us to reach more medical students, pharmacy students, nursing students, and so on. So with that, support the sponsor, meded101.com/store, S-T-O-R-E. We've always got a growing list of resources there that can help you with various pharmacology practice items as well as board exams potentially. And if you want to reach out to me, Eric Christensen, PharmD, BCPS, BCGP, you can find me on LinkedIn. Otherwise, mededucation101@gmail.com is my primary email, and I do my best to try to reply to everybody that I can. All right, well, I thank you so much for listening today, and I hope you have a great rest of your day.
With the Lucky Land Slots, you can get lucky just about anywhere. This is your captain speaking. We've got clear runway and the weather's fine, but we're just going to circle up here a while and get lucky. No, nothing like that. It's just these cash prizes add up quick. So I suggest you sit back, keep your tray table upright, and start getting lucky.
Play for free at LuckyLandSlots.com. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18 plus terms and conditions apply. See website for details.